Hello friends, I am Dr. Bharat Mody from Welcare Hospital, Vadodara. I have spent what I would think is almost an entire lifetime working in the area of total knee arthroplasty and arthroplasty at large, but certainly much more focused on the total knee arthroplasty. And on request of my fellows and students, I have decided to come up with a series of lectures which will take you through what I would consider as a primer and as an overview of understanding the science and art of arthroplasty. Friends, if you have any inclination to go into further personalized discussions on this matter, you are most welcome to approach us at Welcare Hospital. We will be exhibiting the contact information for that. And for any questions that you might have, it will be my pleasure to help you understand and navigate your pathway in this area of work.
Good morning, gentlemen. So today we are just about to conclude this marathon lecture, which we would have thought would have been an 8-minute lecture in a typical conference, how to take primary bone cuts in a TKR. 8 minutes would also be considered a bit of a luxury. And we are now on the 5th, at least 1 hour long sessions. And that tells you something about how the tiniest, that literally the tiniest of actions in a surgery has so much that goes behind it in terms of the thoughts that you should have, in terms of the understanding of how to hold a knife you should have, etc., etc. Yeah. So now we are almost like our recently concluded Indian elections on the 7th phase of to conclude that basic topic of how to do primary TKR. So we have done our bone cuts, and the last lecture we finished off with the bone cuts. We are now coming to the point. Next, please. Wherein we have already taken our notch cut, etc. So you can move forwards, and we are now about to do the trial implantation, and then finally the cementation, and then the suturing. So let's go one step further up, and one more, and yeah, let's go further up, further, one more further. Yeah, we can sit here. So this is what a typical trial implantation thing is. You have done your bone cuts, you have assessed your gaps, and now you think that it is time to do my trial implantation. So you put your femoral component and you do your tibial tray placement along with the insert, which means basically reduction. Even here, depending upon the system you are going to use, you will have to be careful even during this final step, presuming that all the steps that you did earlier on were all okay and good, and your gap assessment, which you do by putting a rectangular block of metal in the extended position and in the flexion position, that also looked quite okay. But many times you might find that when you actually put your implant components in position, which means the femoral component, and then you are about to put your tibial tray with the appropriate size insert. Suppose your block assessments had been for 10 millimeter insert gap, implant, and you are now taking that same corresponding size of tray and the trial insert, and yet when you try to put it in, you will find it to be a bit of a challenge or a struggle sometimes. Let me stop at that and try to stimulate your mind. Why would that happen? Why should that happen? When your gaps have been perfectly created, your rectangular block seems to do absolutely superbly, and yet when you put your implants, you suddenly end up finding a bit of a challenge or a
because the trial implants also lead to the surrounding soft tissue being tensioned sometimes. So that can cause, which a spacer block wouldn't do, because it's within the joint and it's smaller in size.
So very well perceived, but I will articulate it a bit different to make it more precise. What you mean is that with your rectangular block placement between the two bones, femur and tibia, obviously you are creating some amount of tension in some of the fibers which make up this entire envelope called the joint capsule, which also include the collateral ligaments. The cruciates you have removed now, so they are out of any further play. But certainly the remaining capsule with the collaterals, the posterolateral corners, the oblique ligaments, so many different fibers, they are all into play. And when you put your rectangular block, there are only some fibers which are going to be tensed up, which you mainly sort of assess as collateral, mediolateral stability. However, when you, as I have brought it out in our informal conversations from time to time, that each one of these ligaments, they are designed to get tense. A part of that ligament, it gets tensioned in different arc of the movements, and that is dependent upon the contour, not only the thickness of your rectangular block like thing. They come under the influence, they respond to the contour and the volume that you place once you put your trial implants. So those same capsular envelope which look to be perfect for rectangular blocks might not be that perfect in a given case, where they are the collagen type is such that they are very ungiving, So in those sort of things, the moment you put a femoral component and then try to put your tibial insert, you might find that envelope is suddenly behaving a bit differently than what it behaved with just rectangular blocks. And this is exactly the point I make when we evolve these lecture series to the level where we start discussing the merits and demerits of alignment or robotics and all that, wherein the entire argument is based around wanting to create a situation where it is a completely anatomically natural knee, the way it was before you did a knee replacement surgery. It's a paradoxical status of affairs. You cannot create a natural knee once you take away you start cutting the lower end of the femur and the upper end of the tibia, but that will expand that ideation and arguments later in some other context. But even in this very basic little thing, what you just see is reflective of that. So again, even when it comes to this late stage, number one, two things. One is you will have to try and understand that if you are going to use, and this is very critically important, you guys, this is at the practical level, not at a very high understanding of the science of arthroplasty, just a very basic practical level issue. If you are going to use a modular tibial insert system, you have a bit more flexibility available. You will have some more flexibility available at this stage as compared to if you are going to use a monoblock tibia. And what do I mean by this? If you find that when it comes to trialing, now you are finding it tight, irrespective of whatever you have done. So you put your femoral trial component, that is easy, that's never a challenge. It's when you now start putting the tibia that you might find it's not going in. Now in a modular system, remember, in a modular system, after you have cemented your tray, you pick up the insert and then you have to, I call it the front loading opportunity. You have the front loading opportunity, which means you can tilt it a little bit. This insert, you can tilt it like this, and the posterior edge, which is at a higher level than the center of the insert, that posterior edge, you can tilt it up like this and slip it around this condylar convexity, like so, and engage the grooves with the tongue of that insert and then gently tap it and lock it into position. That can allow you to get away with a tight situation. But if it is a monoblock tibia, then the only way you can do it is by taking the tibia out like this, put the entire insert plus the tray and cement it into position, and now you will have to reduce it. And that reduction, see look at this rubber band. It's here, and now you have to reduce it. But when that condyle has to climb the lip, it it will require itself to be able to stretch a bit before it sits in and then becomes lax again. Lax in the sense just about appropriately lax again. So that challenge, you have to be very alert about this. In fact, this challenge is the reason why all the initial tibial components which were in the form of all poly monoblocks, the world became addicted to what you see these days as the vast majority of instances being a modular system, which means you have a metal tray and on top of it you can then keep on changing the insert whichever you feel appropriate. It is that convenience that endeared it to the surgical fraternity, along with, and I don't know how many of you can remember the historical lectures during the history of implant selection and the history of evolution of implant designs. I had mentioned a company called Cintor, CINTOR, who first introduced the titanium trays. And these trays were introduced because of the finite element analysis studies of a guy called Bartel, Bartell, Bartel. Bartel in the mid 1980s, he published a study in which he said that the implants that were available then, the all polytibial implants, which were just about 4 millimeter thick, many of them were just 4 millimeter thick, and those 4 millimeter thick implants could be bent, but they were bendable. It's plastic end of the day. So if your bone underneath that tibial component was also soft, then when the patient walked, that little bit of bending that happened along with the plastic bending like that, it broke the cement mantle and there was early loosening. So this bioengineer came up with the idea that how about ensuring with a guarantee, irrespective of the bone density, let's ensure that the base that is available to the plastic is rigid, which means a metal. And that's how the metal tray came into play, because of that finite element analysis study of Bartel. And once the metal tray was introduced and that was developed into a modularity aspect, the surgeons found that more endearing. Then hardly any surgeon understands why the metal trays were introduced. The metal trays were introduced not for convenience, they were introduced as a result of this study by Bartel that this will help you prevent the flexural bending of the plastic, although that was later overcome by just making the plastic thick. So, but then surgically, as I have explained to you just now, that surgically you have to be a more adept surgeon if you want to get your reduction every time, and once in a while it can be a nightmarish situation. So whenever you are doing monoblock surgical implantations, do a dry test, not with trial implants, because there is no trial implant which will force you to seat the tibia entirely even in a monoblock. So do it with your actual implants, and even with a trial implant you can do it. And the way I do it is, I will put the end, I will dislocate the tibia forwards, put the trial implant, keep it pressed like that and simulate it that way. So you can do it, but most of the time you think, for example, if you are using a Indus knee, at the trial time you don't have a stem in it. It's just a tray and an insert like this, even in a monoblock tibia, but the trial is like this. So if you are not sensitized to this aspect, you will just end up doing a reduction, you think everything is hunky-dory, until you start with the real implant cementation. Cement is already being mixed. You don't even know that it's going to be a challenge once I put the implant in position, and it will not reduce itself. And if you then in panic force it, you will rip off the collateral, the medial collateral.
In these situations where you've done your trial run with the final implant and you see that there is a little bit more tightening than you were expecting, so what is the solution? Do you downsize the implants or do you release the implants?
Good man. So you are now very rapidly graduating to becoming a thinking surgeon, and that indicates two things. Your questions indicate to me how far have you evolved. or how far are you evolving into understanding what you are doing. So very good. Well, in theory, you can relook at your tissue balancing and see whether you have left any scope for yourself to now reduce that tension which is causing, let's say, the medial gap tightness. Once you put your trial implants in, although that same medial gap tightness disappears when you are just putting a block of metal in it. Now, the way to do it is, if you think that the medial gap tightness is because of the bulge of your proximal tibial metaphysis, and if your implant tray, once seated, allows you to take away that bulge from here, again, if I can show it to you on this, say this is the medial side. So you put your metal tray, trial tray, and there is a bulge. I am not talking about margin of the tibial plateau projecting out. Many times what you would have done is, you would have nibbled off this margin, but and this is a wrong representation of the medial collateral. The medial collateral actually is attached right down here, like this. Ato khali is just a simple model. So if your medial collateral is here, like so, then it is any bulge here which is not the same as the margin of your tibial plateau. Any bulge here will still tighten up the medial collateral. So what you can do is bring the tibia out like this. You have seated your implant tibial tray here, and to answer your question, you can do what is known as the medial proximal metaphyseal osteectomy or osteotomy, whatever you want to give it. So you basically cut away a little bit of that bulge, and maybe that will give you just that little bit of extra laxity that you need to do a proper reduction job in a monoblock tibia. That way. So that's one way. Instead of reducing the size, I would suggest you do something like this. But let's say you have done everything that you need to do and you are not able to still get it. And remember, part of the tightness that happens is not because the final thickness is beyond what should be so. It is just the fact that when you reduce your tibia, when you are reducing it, see here, the convexity of your distal femoral condyle and the raising up of the tibial lip gives that extra 2 millimeter or so requirement, which once reduced will reduce. Now just for that transient phase of reducing it, if you end up making a small size, then you will have mid flexion instability during your actual functioning of that implant. So now there are options to it. How? The best way to teach that is on the table actually, but I'll try my best to. So what's the problem? Why is it that you need to talk about all this when you are doing a monoblock tibia? Because you have to bring it out like this, and in a case where you are doing, I need to qualify it one more, which I should have done it early on. This is a issue only when you are doing a posterior cruciate sacrificing, because in a posterior cruciate sacrificing design, the insert will not be like this. The insert will have a peg, the spine of that here, and that typically would say that if you have cemented your tibial component, how will you then put your femur in? Because now that peg will come in between, depending upon the design type of your femoral component. Here, in this design type, even if there was a peg, it would not have come, but then once you get a box, which means you have a posterior wall here, then it will impede. So then there are ways. For example, in the Indus knee, what you do is you still first cement your tibia, then bring the femur up on top of your tibia, and now you have a peg here, but you, instead of wanting to fit your component like this, you gently tilt it and then lock it onto the femur. So these are manual maneuvers which will be best explained if you see it once, and then you will understand, oh okay, this is how I can solve this problem. So there are many ways to skin a cat. Doing a reduction osteotomy is one of it, but then this is also another way of doing it. And this again brings me to that point that end of the day, to be an expert in your area, you need to keep on doing that thing again and again and again. 10,000 times is the magic word. You become a world expert if you do anything 10,000 times. And this is, read that book by Malcolm Gladwell. It's called The Outliers, the title of that book. This is a very easy book to read, small book. Read it. Outliers. People who are outliers from the median. Performers who, whether it be a basketball star or so a big sports person or an artist or a surgeon or a marksman or whatever. He has done an extensive study about what makes those who become world experts to be so. Why do they become world experts when there were so many others who were doing the same thing in that same area of work? And again and again and again, when he did this data analysis, he realized that there is nothing more to this secret than the fact that they ended up doing that same thing so many times that they understood the tiniest of nuance of that action to the point where they become world experts. Now, is it an ironclad statement? No. You can do the same thing 10,000 times, but then you also have to have some amount of engagement with what you are doing. If I keep on doing that surgery 10,000 times but without any application of mind, it's just at a basic reflex level. I do bone cuts, fix it, bahar jaake, So I don't think that can work to make you a world expert. It will make you a competent person in that action. Certainly competent. उसमें कोई doubt ही नहीं है मुझे. But an expert in my understanding is someone who is so good at it that others come to ask his advice or get teachings from him, or he can add further value and push the limits of what it was that was available before he spoke. Those sort of things. So 10,000 times is your magic number. So even in the small act of just trialing of the implants, there are so many nuances, as I just made you understand. Whether you are trialing a system which is going to allow you a modular tibia, or whether it's going to be a monoblock tibia, whether it's going to be a component with lugs in it, the final component having lugs in it or not having a lugs as far as the femur is concerned. Most importantly, when you are putting your trial implant, if you see some resistance, especially in a posterior cruciate sacrificing design where you have created that notch, do not be rough in your implantation of the trial. आपने जोर से थोड़ा सा ठोक दिया, then you might end up having a condylar fracture, at that late point in time. So trialing is also a very sensitive act. If you, for example, have done it and now you are trying to reduce, but you are doing too much of a pressure, you might still end up ripping off your MCL, especially in a rheumatoid case, especially in osteoporotic bones. So be alerted to that fact. Again, as you saw in that incredibly complex dissection that we did yesterday for that mega prosthesis, how despite everything my takeaway from that case of yesterday, which we worked, by the way, bring that 3D thing and put it on my table please as soon as this lecture is over. It must still be lying in that operation theatre. So my takeaway from that lecture was that the surgical exercise was that I had not understood. I was expecting, but it was a bit more than what I had expected in terms of the impact it had on the flexion extension movement after I had already done everything appropriately. And what am I referring to? the dense fibrous tissue that had developed because of the years old sinuses that had existed here, the discharging infected sinuses. So the medial tissue sleeve here was also a band of intensely dense fibrotic tissue, like it was here on the lateral side, where as such you have your iliotibial tract, but in this case, because of those previous incisions that had happened for plating, etc., that iliotibial tract had turned into a much more dense and unyielding structure here, especially in the posterior lateral side. So the posterior lateral side was pushing the tibial tray into internal rotation when extension was happening, and the medial posterior medial band of that dense thing was engaging with the femoral condyle and creating like a pivot shift type, that it would tuck karke aisa, once it goes past it, only then would the patient have appropriate. And when I released the tension in both of them very carefully, and then both these things were resolved, But so that's an on table. But the ability to understand this, it comes with years of work along with application of mind. That sensitivity. So many times I see surgeons who will encounter it, but they will not be able to dissect it out as to why is that issue happening on table. And then, despite the best of efforts, we saw that there was a partial eversion of the patellar tendon from the tibial tuberosity. And again, to recognize it, to take corrective steps, and I'm pretty sure that person will do now okay, that re-anchorage of the patellar tendon onto that tibial tuberosity, especially with that thin layer of periosteum that had also been part of the tendon side of the story. So that will cause adherence very quickly, So now you've done your trialing. Next, please. So this action of doing a proper job of pulse lavaging is extremely important, because your entire longevity of construct survival is depending upon the interlock of the bone cement with the trabecular bone, and the trabecular bone lattice work, if you clean it up with pulse lavage, which is different from just pouring water on it. The pulse lavage has got a very distinct ability as compared to just pouring water. So do not mix up the two. Pouring water at the most might take away some debris and some sedimented bacterial load. But pulse lavage is what opens up that lattice work. And that opening up of the lattice work is an incredibly important part of adding to the long-term survival of the implant. I have done this all my life, right from my early stage of my career. And that's why you see 22 years down the line, those follow-up cases as and when they end up suddenly coming for one or the other reason, and the implants are still sitting rock solid, So next, please. So that's how it should look. And now we are doing, and see what he's saying is that when you dock your trial implant or real implant, whichever is both, just make sure that you have aligned it properly. If it's a slightly malaligned, and that can happen in heavy obese cases where there is fat encroaching, by this time the assistant is tired, you two are also not in the most peaceful state of mind because the air conditioner has not been performing well, you are hot and hungry and hypoglycemic and you want to get over with it, and in that last few minutes, if you are malaligned here and you hammer it, and you might have a fracture on that moment, So next, please. The cement, there is a particular way of doing clean, good cementing of your bone ends, So you would have seen that you need to understand every cement has its own personality, if I can use that poetic word. But otherwise what I mean is, in purely broken down physics, it has a different rate of becoming viscous depending upon its chemical composition, the temperature of your operation theatre, the humidity levels of your operation theatre, the way how much manipulations are happening as you sort of handle it. So all that, learn how to recognize when the cement is just right. If you leave it a little bit too late and it becomes too stiff, it will not ingress as much as you would like it to be. If it is too early, it will become a messy affair. So, for example, when a cement that we use in a routine sense, the Smart Set DPU product, it has its, what are its characteristics? That it becomes usable early on in its cycle. So let's say at 1.5 minutes it will stop becoming sticky, but it becomes very stiff early on also. It will not become rigid, but it will become stiff to the point where it might not go as much as you want into those lattice work of the trabeculae. So you will learn this. The fact that you have been sensitized by this talk, now as and when you will handle your cement over a period of years, you will learn to understand all this. Yeah, આજે ગરમી વધારે છે એમ કરો જો the only the look itself, many times the regular, the cement is appropriate to handle by hand when it loses that tiny watery sheen on top of it. That watery sheen जब तक होता है उस पर, if you touch, if you handle it, it will become a bit sticky. So you have to anticipate that. So you push this in. It is known as digital pressurizing. There have been many attempts at bringing in some products which can help pressurize, which means वो करके फिर you just put that sort of a cover on top of it and then pressurize it. But the same thing, you don't need, it's like trying to do the same thing here, going like this rather than catching your ear here. You can just do it once you have understood what is needed to be done. Next please. And then you put the real implant in. Next please. And then take that cement out carefully, cleanly. When again, something as simple as this, there can be an entire 5-minute lecture only on this, okay, how to take cement off. When will it be, how to take, so many times, so you have seen me, that it's highly regulated in my action plan. Here a size 15 knife, I'll run along it and then with the knife edge, I'll just do this and it will come out with a strip like so. But on the tibia, that same thing, the knife doesn't work properly. There's a reason for it. Even here, the knife might not work if your aspect ratio has been such that your femur is quite wide, your component is sitting and you have cancellous bone on the edge. Normally, because you have an appropriate sizing, in terms of aspect ratio, your blade of the knife will be running on cortical bone. But if it is running on cancellous bone, that blade keeps on cutting into the cancellous. So usme then you change to a McDonald's and strip it off. So you have to be an expert mason. Look at some good mason when he is next time around, when he is pottering around your house doing some construction work. The way in which sadak karke marega and nikalega, so it will be a beautiful way in which that excess cement will come off from the brick joinery work. So that same thing. And why? Not just because it has to be a good exercise. I mean, you are an artisan as much as you are a scientist, in this area of work. But because if you leave too many cement spicules behind, not too many, even one is too many actually. If you have fragmented your cement when you are taking it out of that wound, and there are too many cement, particles, and you miss out on clearing some of them, they will act as third body wear particles, and that's the fastest way of destroying your plastic.
So onto this point, I wanted to ask you. So it's not a quantifiable question, but I'll still ask you. Would you rather take out the cement completely so there is no third body wear, or would you leave a little bit more on the side so that it sticks better and its longevity increases? So this is a question that is not quantifiable. It's always
It is very quantified actually. It's a very, very detailed perception of the dilemma that a surgeon at some point will face, but you have addressed it early on. And it's not a dilemma as in life or death or whether Bhajapa or Congress dilemma, but but it is a dilemma. And how do I look at it? As and when, as long as that cement protrusion is not going to turn into an osteophyte, into a cementophyte, which means it is not going to interfere with my ligament tensions. Number one, I will not be paranoid about absolute clearance. But because I am doing this and I end up getting absolute clearance, that's fine with me. Once in a while, like yesterday, Kshitij, when that tibial tray of the hinge joint was, the cement was setting, and you pointed out a small cementatious wall here, and another little wall I kept here like so, and like here, not protruding beyond the margins of the insert, but so. And why did I leave it? I left it because to me that solid little strip wall was actually a very good anti-rotation force in an implant design where the keels were very minimal, because the design of that particular implant endo model of the Link range of products, it doesn't have a deep enough or a long enough profile of that keel. So it has very minimum, the metal tray, it has very minimum anti-rotation ability as far as the proximal tibial engagement is concerned. It has anti-rotation in terms of it being a square extender rod, and therefore once you put an appropriate size rod into the femoral, into the tibial canal, and the cement becomes rigid around it, and then it will not rotate, which is not the same for a cylinder within a cylinder type of a arrangement. But in this particular yesterday's case, I used that as an extra little thing to combat the proximal thing, especially in a woman who had a bit soft bone on the proximal side. So those sort of tiny understandings, but all these iterations, whether we remove it completely, whether we leave, sometimes strategically leave behind a strip of dense cement, but which is engaged in the cancellous bone. And that happens when your, again the same thing, aspect ratio. If this component was sitting here, but the femur was expanded so that you have a cancellous strip of bone left here, and a strip of cancellous bone left here, a little bit, then I would actually press my last amount of, as I take my McDonald's and remove that, as I'm removing that cement, I'll be like so, like a mason who will press that excess, is pressing some cement into the brickwork and removing the excess like that, and that seals that particular cancellous strip bone, and it prevents unnecessary bleeding later once the tourniquet is released. So these are tiny things. Many times, as I said, I left a little bit proud cement strip wall, as in yesterday's case, but with a different intention. So you can keep on tweaking your surgical exercise to every tiny step you can, every stitch that you will take in the closure is a work of art. So you need to understand, but once you have understood this and once you have ignited your mind for the work that you are doing, you will yourself build this momentum as you go along. Next, please.
In PFC Sigma knees, there's a metal back notch. So I have noticed that you don't cement the notch part of the bone. Is there any particular reason, because we only cement up the condyle?
Very good. So that's again a very good observation you have made, and it's a very relevant question. So you have two types of designs in a posterior cruciate sacrificing system in the femoral component. Some companies bring in what they call as the open box. So the femoral component does not have, here you go. So the femoral component does not have a wall in the back side of it. It will have a strip of metal and this, because this is important, this part. This is what actually engages with the spine. So this is important, this much. But this plastic thing that you see and the wall behind is many times of an open design. Those who have kept it as an open design do it because they say, and they rightly so, they say that it allows the supracondylar nail to be put in case of a future fracture if it happens, etc. Those, by whatever reasons best known to the designers at that point in time, those who developed a closed box is a closed box. But the reason why I don't cement the backside of it is that if and when you have to take this femoral component out for reasons of revision, due to infection, aseptic or septic revision, it is impossible to engage or remove or break that cement mantle at the backside. All the other areas you can access, that you cannot access. So there is no point in putting a cement blob there. Your engagement of the femoral component with the, so remember, what do you think is cement? Is cement a glue?
It's a binding agent between the
But how does it bind?
It seeps into the rices of the bone, and similarly the undersurface of the bone. So it's a grout.
It's a grout. So what is the difference between a glue and a grout? Both do the job of binding.
Glue has an adhesive.
Exactly.
It's an adhesive. It's whereas grout will seep into those crevices and the bone.
So grout is a purely mechanical bondage. A grout works by engaging both surfaces by virtue of a mechanical lock. A glue binds by its stickiness. It's a chemical property or physico-chemical property, wherein it is the stickiness that a cement is not sticky once it goes past that polymerization point, you know. So when you have a grout, you need to have, that is why one of the important things when cementing would be to clean it up with a pulse lavage, and if it's a dense bone that you have, then you do multiple small drill holes, because bone cement is a grout, it is not a glue. Okay, very important. Glue and grout, very different things. So bone cement, polymethyl methacrylate is a grout, it is not a glue. So you cannot remove this femur, or you can remove it, but it will come out with some unnecessary bony damage if you grouted it behind that closed box. That is why we would not do it. And if you have done an adequate job of your engaging the bone cuts appropriately and then creating enough lattice work or ability for the cement to grout inside the condylar or onto the condylar surfaces, then your hold is so good that you don't need to stick it at that backside. Okay, so next. Yeah, next. See next. Okay, that's good. Okay, go back. So that's my all poly days. So I have put the tibia forwards, then I have put my all poly tibial component next, and then clean. See how cleanly it is done. And now when I reduce it back, I have to be careful that it is neither too lax nor so tight that it will not be reducible. Next. And that's it done. And see how clean the surfaces are, the borders, once the cementing is done.
Sir, since in this view we can see a slight cement band on lateral aspect. So how much is the appropriate to be left behind and how much the implant should be taken? Because we see we punch the final implantations, and some people do it twice or thrice, some people give a little bit of more hits. So how much should it sink and how much?
So many times you will find that there might be a more sort of thicker looking cement mantle here as compared to somewhere else, and that's because when you are taking your distal cut, your blade had dipped in on that side. So there will be some, during trialing you will see gap, air, and during cementation you will see a slightly thicker cement layer. How much you have to bang it in? You cannot bang it until you break the bone, sort of thing. You have just got to sort of tap it into position and then pressurize it so that all the excess cement oozes out, and now your metal component is sitting on some rigid bony engagement. Uske baad, if you still end up getting some gaps which are now filled by cement, that is the role, that is why you have cement, that it is a grout, it is going to fill up that hole. And cement is excellent under compression, it is pathetic under tension. So if you have a slightly thicker layer of cementation, in itself it is nothing to worry about. That's the job that the cement has to do. So in your if you get a mistaken idea that no, I need to get a very slim, and you keep on hitting, you will create a fracture. That gap is there for a reason. That on that side your, whatever the reason, the reasons could be different, but it's basically a mismatch between your bony contour and the inside of your component. But as long as they are minor, that is what the cement's versatility is.
It is more of a haptic feedback when you feel that it is already settled and this.
Yes, absolutely. And then even more importantly, when you extend your knee, no matter how much you have hit, when you extend your knee and the amount of pressure that is generated, if you want to understand how much pressure is generated, keep your fingertip next time whilst you are in while you are extending your knee, and you will understand what is the sort of pressure that is generated by that action. It's incredible. Next, please. And the patella, this is a lecture in itself, whether to resurface the patella or not, and we'll reach that at some point in time. Next, please. Yeah, good. So we have finished. I'm not talking about how to suture up. Maybe that also is a small little talk to, because that's the one place where you guys can harass the senior surgeon. He ends up giving you the suturing, and all his work can come to naught if you mess that job up. So, but anyway, quickly to surmise, suturing the quadriceps layer, typically in the knee replacement all across the world, it has become now standard practice. You do it with non-absorbable ethibond type of suture, and I think ethibond is as good as any other. So ethibond reinforced with a continuous, interrupted ethibond reinforced with a continuous vicryl. I think we use size thick 2, 1 in our theatre, and then you do your subcutaneous, and then you do, normally knee replacements people don't do a subcuticular. You do a good subcutaneous, then if you required, maybe you do a subdermal, depending upon how the tissue thickness is, and then finally you can do either a mattress, or these days staples are more convenient to do. The important thing, the most important thing is, while suturing, that the area where you will have treachery later, especially in heavy patients, is the patellar corner here. So if the suture line is going to come apart in the postoperative period, when you are doing like this in a medial parapatellar, the first place from where it is likely to come apart is here, this much. Not here, it is here. So from here, the muscle layer can come apart. So there you have got to have a really good hold, and that all depends upon your very first step, which is the incision. If you don't leave a good tendinous cuff on both sides, and you leave only a red muscular tissue here, it will cut through. If you don't leave a good little thing here, either if you have been, for whatever reason you have not left it, drill a small hole. Always keep a size 2 millimeter or 2.5 millimeter K wire on the tray. Drill a couple of holes and pass your suture through the rim of the patella, rather than, because if this comes apart here, 100% you will have to take your patient back into the theatre. In your early days, you will be very, very terrified that now it is an infected knee, whereas it is not an infected, it is just a mechanical leakage. It will become infected later if you are unlucky and if your patient is unlucky. So suturing, actually, on a serious note, is a very integral part of it, all the important things that you do, because wrong suturing can lead to so much heartburn, and you will destroy your reputation as a surgeon. That patient will think, अरे यार बहुत तकलीफ हो गई, complication हुआ, ये वो, all that it had, the real cause was that a couple of stitches that you should have taken, you have not taken properly. So this is where it will come apart at the muscle layer. This is where sometimes you might find that your sleeve is not suturable in a varus knee, where you have straightened it out from here to here. Physically, it is not possible to bring the two edges together. So in that case, your subcutaneous layer has to be very tight so that there is no leakage of fluid. Otherwise, you will find leakage of fluid. And subcutaneous, sometimes, even when it is not given way here, but you have done a lateral release, and you have done a lateral release at a level which is communicating with your subcutaneous stripping of that muscle layer. See, that's why I'm saying when you do your incision, skin, subcutaneous fat, then you do it, then you, when you remove the fat from the muscle, do it only to the extent where you require it. If you have done it too much and now you have done your lateral release, and that lateral release is actually now communicating directly in the subcutaneous layer, then there will be leakage of fluid. And then if your subcutaneous suturing is not watertight, that leakage will come out, and that leakage will exactly appear. It's impossible to distinguish whether that leakage is coming from here or it is giving way of the suture from here and it is coming out. Because if it is from here, you will have to go in and redo it. If it is from here, maybe a few days of immobilization, and when the layers start sticking to each other with biological healing, it will seal off. So all these tiny things, even your suturing has a, and lastly, the epidermal layer, the dermal and epidermal layer, if one of them is like this, it has invaginated down underneath the other, it will not heal in time, and your patient will find, they will live with a bad taste in their mouth, because you will not be able to remove that suture. Even if you remove it, it will open up like this, some drop of serum will come out, they will think it is pus, all that. So this tiny part is so important to gain your goodwill and to have an uneventful recovery after having done a marvelous job in the main part of the operation. So gentlemen, the fact of the matter is, ours is an area of work where right from the first to the last step, each has an importance that cannot be ignored or underestimated. But if dufferts like me have done it, I'm sure bright guys like you will be able to do it if you put your heart into it and your mind onto it. Good. Let's do the rest of the work today. Good.